Morning. So when we talk about local anesthesia, this is when, we use a chemical agent, and what it does is local anesthesia interrupts sensory transmission. So if you think about it, when we put a block, I'll use a ring block as an example. If you were going to do a declaw, they'll put lidocaine. So lidocaine is a common agent. And if they put it in a ring around the carpus, when when the nail is clipped or the declaw begins, normally a sensory nerve would send a signal up through the sensory nerve. But the way local anesthetics work is they block those sodium channels. If you remember, again, always back to anatomy, but when a nerve sends a signal, it opens that sodium potassium pump. The sodium channels open, sodium fluxes into the neuron, and that's how an action potential begins and sends the signal. The local anesthetics prevent those sodium channels from opening. So therefore, the sensory signal never makes it to the brain, and therefore pain is never sensed. So there's no reaction. So again, like if you go to the dentist and get a block for, a cavity or something, they're working at that first level of transmission of the signal. So it blocks and it disrupts that nerve signal. And so there is a temporary loss of sensation. Obviously we all know, like when you go to the dentist, eventually an hour or two later, you kind of go, oh, you feel the effects eventually. But at the moment that you're doing the procedure, we're able to stop this. Now, when would we use local anesthetics? Well, a tractable animal is an animal that you're able to restrain, or you're able to do this to. You can do this when you don't want to do general anesthesia, or if you have a patient that's high risk, meaning you don't want to use a lot of anesthetic. There's a lot of indications. If you have like a critical dental patient, a very older geriatric patient, cardiovascular disease, and you want to minimize gas anesthesia, obviously if you use local anesthetics and they don't feel pain, you should be able to use less inhalant, less injectable agents. And if you can't do general anesthesia, and again, I kind of do this before I do large animal, because a lot of local anesthesia is used in cattle and in horses, even in pigs. So, and I would say more and more vets are using them in small animal, but there's definitely a need in large animal to use these local blocks, and just to enhance analgesia. So some of the advantages of local anesthetic: overall, they have low cardiovascular toxicity. The one species that you need to know is cats are sensitive to the lidocaine drugs. I'm going to talk about lidocaine and bupivacaine, but they do have a sensitivity. So I will tell you, and I've mentioned it yesterday, is anytime you use local anesthetics, and when you guys are in surgery rotation, you will use local anesthetics, you're always going to calculate that animal's maximum dose. So when you give it, you can't go over a certain amount. And cats are always going to have the lowest amount because they are sensitive to these effects. They are relatively cheap, and they give very good pain control, and the patient has minimum recovery time from them. So, but I will tell you, ruminant obstetric and abdominal procedures, almost all C-sections and on cattle are standing C-sections. They'll get a sedative and they'll do a local block that we'll talk about to the flank, and they can do the C-section with them standing. Standing sedation in horses, we do a lot of joint blocks in horses to test for lameness. And then in any general anesthesia, you can do testicular blocks, you can do epidurals, you can do tail blocks for tail amputations. So there's a lot of options. a lot of different blocks that are just going to enhance analgesia. So let's talk about a couple of the common agents that you can use. And I will talk about different ways you give them. Like, you can give them topically. Most of the time when you use local anesthetics, you are giving them in an area in the tissues. Again, you're not typically giving them in the vein or IV. Normally, you're going to infiltrate, meaning you're going to put it in an area in the tissues, like in the sub-Q tissues, or just right under the skin. Now, I did talk about the MLK CRI, that you do put lidocaine in that bag, and that is given IV. That dose is pretty low, and so that is given systemically. So when I say systemically, you're giving it in the vein, and it's traveling through the blood and through the body systems. But most of the blocks I talk about, you're giving it in the tissues. Now, but you always remember, anything that's given in the tissues is going to get absorbed in the bloodstream, and that's how these agents are going to be broken down. So the most common agent is lidocaine, and one important thing for you guys, especially getting ready to go into surgery rotation, is you should always look at your bottle, because lidocaine can come as a 0.5%. It can come as a 2% solution. And especially when you get ready to start the boards, you have to remember how to convert that to mgs per mil. If you learned the cheat way, anytime it's a percent, you add a 0 to it. And so a 5% or 0.5% solution is 5 milligrams per mil, and a 2% solution is 20 milligrams per mil. You basically move the decimal point one place to the right. So if you move that, 0.5% is 5 milligrams per mil. Now there's a whole calculation on how to do that. That's just the cheat way, because Lasix comes as a percent, lidocaine comes as a percent. There's a few other drugs that come as a percent solution. And again, when you calculate it, you have to calculate it at mgs per mil. So that's the way to convert it. But lidocaine is the gold standard. It's very, very cheap. You can dilute it with saline. I mean, it's an aqueous solution, so it's not thick. It doesn't necessarily have to be diluted, but sometimes when we give these in blocks, they will add saline, and it helps spread it out. So sometimes they do that. There is bupivacaine, and that is in the same family. Bupivacaine is just a little more expensive. It comes as a 0.25 or a 0.5% solution. Now, it doesn't kick in as fast, but it does last longer. So I always tell you, how do you figure out the difference between drugs? Well, sometimes it's cost, and a lot of times it's duration of action. If two drugs belong to the same family, and I say this over and over again, what's the difference? They obviously don't do the exact same thing. Now I will tell you, bupivacaine, if you're doing a lot of epidurals or spinal blocks or intrathecal blocks, which is when they put a catheter in near the spinal cord, you're probably going to use bupivacaine because it lasts longer. There is also a sterile form, a preservative-free form of bupivacaine, because anytime you use it in a joint or near the spinal cord, we don't like to use the preservative forms of these drugs because it can cause reactions. So that is an advantage. Now, I'll talk about Procaine and bupivacaine, but basically the two main ones that you'll see are lidocaine and bupivacaine. And then I'll talk about the ophthalmic local anesthetics. I haven't used a lot of tetracaine, but proparacaine. One interesting thing, and I'll mention it since I'm on this slide, procarapain drops, if we're going to do a full ocular exam, when I worked in ophthalmology, I did a little bit and helped in ophthalmology. What I used to do is when I would go talk to the owner in the lobby, while they were filling out their paperwork, I would put in the Procarapain drops. And then when they would come in the room, and that's like 5-10 minutes before they come in the exam room. When they come in the exam room, we put another couple drops in their eyes, and then we would take our history and do our physical exam. So the whole time while the client's waiting, the eyes are getting numb. We're going to basically like dilate the eye. So if you've ever been to the eye doctor, you know, they'll usually put in the drops, and you have to wear the sunglasses because when your eyes get numb and they're dilated, if you go out into the sun, you can't constrict your pupils, and it can get, you know, very painful to have all that light. So that's usually why when it's happened to me, they give me these big sunglasses to wear for like an hour or so. They're like, until your eyes go back to normal. So, but you know, we need the surface of the eye to be numb, and we also need the pupil dilated to be able to do a full ocular exam. So the other way we can use Procarapain drops, which is interesting, sometimes in the ER, we have to put in nasoesophageal tubes. Sometimes we have to put in nasal oxygen, and we use Procarapain drops, and we drop them in the nose to numb, you know, to numb the nasal cavity. So when we place like a feeding tube or a, you know, a catheter in their nose, it numbs. So even though they're eye drops, we have used them in the nasal cavity to numb them before putting in these feeding tubes and these, you know, stomach tubes if we have to do it through the nose. So it's another kind of application of these drops. So the thing about local anesthetics is they're not general anesthetics. So they don't typically cause CNS depression. They don't usually cause sedation, you know, unless you were to get it in the vein. If you give lidocaine IV, it can cause, it would have to be in pretty high doses to cause any level of sedation. So typically they don't affect the CNS. They have local effects. So they're going to numb the local area, but we shouldn't see the CNS effects. Very few cardiovascular or respiratory effects unless they have a reaction to it, or you were to accidentally give too much if you give it in the vessel, which you're not supposed to do. And most of their action is where you give them. So, you know, on a test, I love to ask questions like, what are advantages of local anesthetics, or what are some, you know, characteristics? This slide is basically saying this. And the nice thing is they don't normally cross the placenta. What we used to do in ER for, and even when I was at Purdue, if the mother was not critical, so sometimes C-sections, we are usually, when you do a C-section and you give them general anesthesia, pre-meds, propofol, isoflurane, all of those drugs that go to the mother are going to the pups because you're giving them in the bloodstream. And we have to be very careful with our dosing because we don't want to depress the puppies. So we have to try to use agents that are minimally cardiovascular depressant. But that's very difficult because most anesthetics have those properties. So if we will do something called a line block. So I would anesthetize the mother, and this is something that techs can do. I would just take lidocaine, and down the middle of the abdomen, right on the midline, I would put blebs. I would inject the skin, and I'd put little blebs of lidocaine where the doctor's going to make the incision. And by the time we get into surgery, she's going to be numb right down the middle, and I should be able to use less anesthetic. So it's anesthetic sparing for the mother, which is also anesthetic sparing for the pups. Now, sometimes you're rushing through a C-section, and some doctors don't want to take the time to do a line block because we kind of want to get in and out during a C-section as fast as possible. But there is a benefit, and I don't have to really worry about that local anesthetic going to the pups. It doesn't typically cross the placenta. And by the time she would metabolize that drug, by the time that drug would go in the bloodstream, we should have the puppies out. Now, you can do epidurals for C-sections. The argument there is again, it's time factor. It takes time under anesthesia. You know, a dog has to be anesthetized to give an epidural. So, and if we're trying to minimize anesthesia time, there's not a lot of times a doctor's going to want to do an epidural for a C-section. So I'm just giving you some pros and cons of when we would do this. Now, again, how do they affect? You need to know they affect sensory neurons. And so the goal is to put the drug very close to where the nerves are. And normally what I mean is you're giving the agent near either a peripheral nerve, or you're going to give it near a nerve root where you're controlling multiple nerves. So there's going to be a couple different ways, but I do want you to know they do block sodium channels. They prevent depolarization. Depolarization is how a signal is sent, and this is physiology, you need to know this, is they never open the sodium channels, therefore that signal is never sent. Now, once the drug does get absorbed in the tissues, you know, again, eventually it's going to be, you know, in about an hour or so, it's going to be metabolized. And then, but you know, usually a local anesthetic is not the only thing we're using for pain. As long as we're giving a pre-med for pain, we're giving post-op medications for pain. Once the local anesthetic wears off, they have something else on board. So again, knowing they have a short duration, we need to know this. Now, it is metabolized in the liver, so you do have to be careful as far as, you know, their liver function. You can do these with patients with liver disease. We may just lower the dose, or those agents could have potentially an extended effect, but that's not very normal. Now, there is a note under here about motor neurons. If you remember, in every nerve fiber, sensory neurons take the signal to the brain. When the brain processes a signal, normally they send a motor signal down a motor neuron to cause a movement. If you remember, sensory is feels, motor is movement. Sometimes these local anesthetics also affect motor neurons. Well, if they affect the motor neurons, you can potentially get some weakness to that area. Now, we tend to see this more when we block like nerve roots, like in an epidural. Sometimes if we do a joint block on a limb. Normally, if you're using it just in a small area, you don't see this as much. But anytime you affect a sensory neuron, you have a potential to affect a motor neuron. And if the brain can't send, if the muscles aren't getting the appropriate signal, that's why you get the weakness, maybe some temporarily loss of movement in that area. So those are kind of some things that could happen. Now, if, you know, it does affect, this is what I was just saying. So in an epidural, usually when you do these bigger blocks, with you're doing more nerve roots, is when you tend to see the loss of motor function. I will say some dogs after epidurals will have a hard time getting up and walking outside. And it can be, you know, up to 12 to 24 hours after an epidural. That's not common, but it's something that we watch for in our patients that have epidurals, and we watch for that post-op. Now, you know, if we're talking about drugs that affect the autonomic nervous system, you know, occasionally if they have a side effect, if we give too much, then we worry about sympathetic blockade, where, remember, the sympathetic system is what reacts to fight and flight. And if we get too much of this drug, now these are some of the bad side effects of local anesthetics. Or say you went to give it in the tissues and you accidentally give it in the vessels, but it can affect the sympathetic neurons that go from the brain to the blood vessels, and that affect the internal organs. And if you affect that sympathetic blockade, because it diffuses into those areas, then you can, you know, we don't get the sympathetic effects, which increase blood pressure, increase heart rate. So now it says here it may diffuse into the thoracic spinal cord. When we give an epidural, and I'm going to talk about this, but I'm going to mention it now, we give that at L7S1, okay, which is at the end of the spinal cord. We're kind of behind the spinal cord. And when we calculate epidurals, there is a certain amount, and we give it at a certain speed. We don't like blast it in. If you give it slowly, because we're really trying to keep the drug caudal, but if you were to calculate a higher dose, if you gave too much or pushed it too fast, if you push it up the spinal cord, you could get up near the thoracic spinal cord. And that's what this is talking about, is if you get up to the thoracic spinal cord, then we could potentially affect those sympathetic nerve fibers. So again, the way we avoid that is we calculate a set amount, and we give it at a certain rate of speed so that it doesn't push too fast and go up to those fibers. Sometimes when we give it peripherally, when you give it on a limb, in a joint, in the tissues, you know, closer to the periphery on the outside, you can get some vasodilation, and that area can look more red, and it can actually feel a little warm. So sometimes that does happen. If you get too much vasodilation, if they, you know, what I think about is if the animal has a reaction to it. Anytime an animal has a reaction, if it causes vasodilation in too many of the vessels, you need to know vasodilation dilates your vessels, and that basically decreases your blood pressure, because tension gives you pressure. Hypotension gives you low pressure. Now, if the vasodilation is in one area on the limb, that's not as much of a problem. But if it goes systemic and it causes a systemic vasodilation, then we can get a low blood pressure. Anytime I do a local block, especially an epidural or a larger block, I watch their blood pressure pretty closely, and I watch their heart rate to make sure, like, are they, low blood pressure, tachycardia, pale mucous membranes would all be indications of a low blood pressure. And again, there's a note here, one of the ways that we combat hypotension or low blood pressure is to give a bolus of fluids. Because again, if you vasodilate the vessels, they need tension in them. So the quickest way to do that is if we bolus fluids, you increase the fluid in the vessels, you increase the blood pressure. So, and obviously I check with my doctor and let them know what's going on. So some ways to give local anesthetics. A common is a topical application. And if it's a topical, that means the drug is applied directly to the skin, typically intact skin. So I'm not talking about putting it in a wound. That's a little bit different. But this drug can penetrate through the dermis. So there's usually, we're talking about like gels or ointments. Typically, I'm not talking about just squirting lidocaine on the skin. These are typically pre-prepared creams, but there's ethyl chloride spray, there's EMLA cream, and hold on one second. There's something at the back door hanger. Okay, so a couple different examples. So now EMLA cream, we don't use this a lot in veterinary medicine. It is used a lot in pediatrics. Like if they have to draw blood on a baby, if they have to put an IV in a child, it is a numbing cream, and they will rub it on the skin, and it will, cause less pain if they have to draw blood or put in a catheter. Now, EMLA cream, the problem is, yes, I mean, so used for kids, it's a numbing cream. It does have to sit. And part of the problem in veterinary medicine is we're dealing with, the fur. Now, if you go to clip for an IV and you were to rub this on and let the patient sit, you do have to cover it so they don't lick it off. So that's another problem is our patients like to lick things off because it does have to sit in order for it to work. Now, splash block, if sometimes we'll do a splash block, and the difference is if you just splash lidocaine on the skin, it's not really going to work. But if you do have a laceration, if they do have like an open wound, sometimes the doctor will just squirt lidocaine. We had a Great Dane that came into the ER that was running around a pool, and they had the pool bracket for the ladder was sticking out, and he sliced open his shoulder. I mean, we could see almost down to the scapula. There was multiple layers of muscle, a very deep, deep, deep laceration. Before we flushed out some of the debris, he was anesthetized. She squirted lidocaine kind of all in the area. So we didn't inject it with a needle. We just literally kind of splashed it on, excuse me, the tissues. A technique we used to do at Purdue is whenever we did thoracic surgery. So if we did a lung lobectomy or we did like a PDA, and a lot of times in those cases, you cut in between the ribs and we open the chest, so we're stretching out the intercostals. Those dogs have to have what's called a chest tube. And maybe you're talking about those in ClinMed 5, but because once the chest is open, you have to evacuate the air because air is going to go in and you have to create a negative chest. What we also did for those dogs is we would inject some bupivacaine because it lasts longer. And what we would do is now you're putting fluid in the chest, but we're not putting enough. What we would do is we would squirt it in the chest tube. And then before we woke them up from anesthesia, we would roll them back and forth. And what we're doing is we're bathing the pleura or bathing the chest cavity in bupivacaine. So hopefully, now it's not numbing their thoracic muscles because this is just being applied within the chest cavity. So it's not going to really penetrate the muscles. It's really just causing some topical numbing and hopefully enhanced analgesia. So that's a technique that can be done in thoracic surgery. You can obviously put it on mucous membranes. Man, I'm sorry. And they do make lidocaine spray and they do make lidocaine patches. We did also have some of these when I was at Northwood. If a dog had thoracic surgery, and again, that's very painful to cut in between the ribs and stretch out the ribs, we would apply these 2 patches, these long lidocaine patches, to the skin right next to the incision so that lidocaine would seep in, kind of like a fentanyl patch. It's kind of like a low dose continuous. These would give us about 48 to 72 hours of local relief. So there are some local topical applications. Now, what's very common is to do infiltration. So the difference with infiltration is you're using a needle to inject it in the tissues near a nerve, and you're typically trying to target a nerve. Now, most of the time we do this in veterinary medicine, when we do nerve blocks, anatomically, there are when you do a dental block, we look at, okay, the zygomatic arch, go to the cranial part of the zygomatic arch, go down. Go near the carpus to the right. You try to use anatomical landmarks. They do have things called nerve stimulators that advanced clinics, what you would do is you would put the nerve stimulator, and when you hit it, it kind of gives like a little shock, and you look for a twitch. And then exactly where the nerve is. Because again, you're just kind of guessing based on anatomy. The nerve should be right here. If you use a nerve stimulator, you can find where the nerve is, and that's where you inject. And this is important, you're not injecting it in the nerve. Do not hit the nerve. That's not our goal. You're trying to put it in the tissue around the nerve. So these are not you're not usually putting a needle in, at a 90-degree angle. We're talking about probably 20, 30 degrees, and you're just trying to get it under the skin. in that, you know, and you're not really tenting. I mean, you may lift up the skin like you're giving a sub-Q injection. And then what we usually do is we deposit it as blebs. I call them blebs, but you're just putting a little bleb of lidocaine under the skin near the nerve. And then the big thing with nerve blocks is so many people in veterinary medicine are impatient. You need to let it sit. You know, lidocaine maybe 3 to 5 minutes, bupivacaine maybe 10, 15 minutes, a little bit longer, to let that get absorbed. I mean, if you're going to take the time to do a nerve block, don't waste it by starting the procedure before the drug kicks in. Now, lidocaine can be used, and this is important for the notes. Some lidocaine, most clinics carry lidocaine. It's just lidocaine by itself. There is a lidocaine with epinephrine added. Now, key points to know. The reason, does anyone know why epinephrine might be added to lidocaine? What's the benefit of adding epinephrine to lidocaine for a local block?
I'm just guessing, like based on like an EpiPen, like maybe it would block like a histamine release or reaction in that area once you start irritating the skin or making an incision.
Well, and you know, you could theoretically say it could help prevent against that, because how does epinephrine work? What does epinephrine do to vessels? It vasoconstricts. So what you're saying is, you know, normally if you have a reaction in an area, you would get vasodilation. So I see where you're going. Typically what epinephrine does when you add it to a local block is it causes the vessels, all the little capillaries in that area, to vasoconstrict. And what it does is it delays absorption of the drug. So it can make the lidocaine last longer. Does that make sense? Because when you give epinephrine, epinephrine is, now everyone thinks epi and CPR, which is true. When you give epinephrine intravenously during CPR, it causes vasoconstriction, and what you're trying to do is force blood flow back to the heart during CPR, and that's why you give epinephrine. And it's, you know, it stimulates sympathetic, so you're trying to get things going in CPR. When we use epinephrine in a local block, if you give epinephrine in the tissues around, those vessels constrict, and if the vessels are constricted, they don't absorb as much of the lidocaine, and it makes it last longer. So the benefit to epinephrine is to extend the life of the local block, you know, probably another hour or so. I'm not talking like 24 hours, but it'll delay absorption of the drug. Now, a lot of joint blocks are used in horses to treat pain and to check for lamenesses. And a lot of times in horses, if they're going to use it for pain relief, they use the epinephrine form because they want to get more time out of that block to give more relief. Now, the big warning, this is key, is you do not want to get it in a blood vessel, especially if it's lidocaine with epinephrine, because if you do give it IV, it can cause that vasoconstriction, can potentially cause an increase in heart rate. So if you're using epinephrine, anytime you go to inject a local block, you're going to go under the skin, and you guys have been taught this with any injection. What's the first thing you do before you push the drug when you inject something? What are you supposed to do? You're supposed to aspirate. Why?
To make sure you're not like in a vessel.
Exactly.
Then it's not sub-Q, it's IV.
Exactly. So if you go to do a local block and you pull back and you get blood, you need to pull that needle out and you need to redirect. Or, yeah, like back it out or completely come out and go in a different spot, especially if you've got epinephrine in it, because you don't want to give that intravenously. It will get absorbed, obviously, anytime you give epinephrine, but it's being absorbed in small amounts. You're not going to get the effects as if you were to give it IV. So again, so I just want you to know, why do we use epinephrine? What's the benefit of adding it? And what are the cautions when you do that? Now, any of these local infiltrations, you know, Intradermal versus subcutaneous is the angle of your needle. You know, normally we're going to want this a little bit deeper if we're going to get around a nerve root. If you want to block intradermal because you're trying to block the skin layer, you can do that. You can give them intramuscular if you're trying to block actually a little bit deeper. But this is going for the superficial tissues. Now, when you do local blocks, you're going to prep the skin. We usually use 22 to 25 gauge needles. We usually use small needles. Obviously 20 or 18 is if you're, you know, using in larger animals. And the amount of drug will vary with the species and the procedure. Remember, each species is going to have a maximum dose. So if you have, like, so again, if I have a cat for a front declaw and I know that the cat has a maximum dose of 2 mLs, that means each limb can only get 1 ml. I mean, I'm going to probably spread it out evenly. If a dog has 20 mils as a total dose and I'm blocking, you know, and we don't always give the maximum dose. You know, it will vary depending on the type of block. But we kind of have to have an idea of where we are with their dose and make sure that we don't go over that maximum dose. And again, you know, lidocaine can kick in about 3 to 5 minutes. Bupivacaine is probably going to be closer to 10, 15 minutes. And the way that you can test the area is sometimes a doctor will take a needle and they'll poke the skin. They'll just kind of go beep, beep, and they'll look for a twitch. Because if they can feel the pinprick, they're probably going to feel the procedure. They might, and then one of the reasons sometimes we don't give the maximum dose is they can give more, or you can wait and let it kick in. You know, you have a couple different options. So if you give, depending on how you place your needle, is going to depend on how long or how good your block is going to be. Because the deeper tissues, if you go like intradermal, you're probably not going to get numbing all the way to the muscle. If you want to numb more to the muscle, then you're going to have to put the injection a little bit deeper. Now, anytime a dog has scar tissue from an injury, if they are, you know, a little overweight, if they have edema, or if they have bleeding in the area, that's all going to affect drug absorption. So, you know, what are things that affect, you know, the effectiveness? That's obviously going to affect it. And if they have an inflammation in that area, if they already have an infection, that's potentially going to decrease the effectiveness of the drug. So the duration effects on the drug depends on the drug and the rate of absorption by the vessels. Again, right here it tells you in the notes that epinephrine can be added to affect the rate of absorption. So how does it affect it? It decreases the rate of absorption, meaning it makes it last longer. That's what epinephrine does. So, you know, there is, again, most people are going to use lidocaine without epinephrine unless you're doing it for, like I said, the doctor wants the block to last longer. That's when you would use the epinephrine form. And if we're if we're talking about a nerve block, what I just talked about is maybe you're blocking under an incision, like, you know, you're blocking just a small area for an incision, for a biopsy, you know, something very small. A nerve block is you're trying to get to a nerve that controls a whole site, an anatomic site. And this can give some analgesia post-op. And the benefit to this, again, is hopefully you use less general anesthesia. Slide 14 is important. These are the types of nerve blocks that are going to be used. Now, I said a lot of nerve blocks are used in large animal, but you can do dental blocks. You guys will go over those in surgery rotation, because if you have extractions, you can block a whole nerve root that will block a whole dental arcade, and you can pull the teeth. You know, I just talked about intercostal nerve blocks for thoracic surgery, you can numb in between the ribs where the doctor is going to make the incision. They can block at those roots, and that will numb that whole area where they're going to make the incision. Limb amputations should always get a nerve block. Now, during a limb amputation, if you guys remember this in anatomy, the armpit's the brachial plexus, and there's a series of nerves that go out through the armpit down to the forelimb. And a lot of times the doctor can do what's called a brachial plexus block. They'll numb, because anytime they, to remove the limb, you have to cut all those blood vessels and you have to cut all the nerves. Part of this phantom pain, there's animals after amputation, they feel like they still have their limb. And maybe they bite at it and they chew at it, because if you cut through a nerve that's not blocked, it will continue to send those pain signals even if the limb is gone. So most of the time when we did that, we would either do the brachial plexus block before surgery, or during an amputation, the doctor would inject lidocaine or bupivacaine into the nerve before they would cut the nerve. So, and they would usually let it sit for about 10 minutes or so before they cut it. So they would numb that nerve itself. And then we'll talk about the paravertebral block for the abdominal or obstetric procedures, the standing procedures. Corneal block is done at the pole. So if you're going to dehorn cattle or remove the horn buds, you can block those nerve roots, and lameness exams in horses. So I'm going to stop there because I know, again, you guys have to get to your next class. Do you have any questions?